is Michael David, and I'm here to demonstrate the lung and thorax examination. And here with me is Mr. David, who's going to be doing the procedure with me. And before that, we should need to ask consent first before we can proceed. So, Mr. David, are you giving me consent to do this examination under recording?
Yes, I give consent.
And can you verify you're 18 years of age?
Yes, I am 18.
Okay, thank you very much. So we shall proceed. But before we can start with our examination, we have to make sure that we wash our hands or just disinfect them with alcohol gel. So I'm going to disinfect my hands first. And then we can proceed. So at the moment, while I'm disinfecting my hands, I'm trying to check the patient's respiratory rate, and he seems to be breathing quite well. The rate is around usually around between 15 to 25 breaths per minute. Anything above 25 would be considered asthmatic, but it doesn't seem to be like that. So we'll now proceed with the further inspection of his chest wall. So, Mr. David, if you would please take off your top so we can have a good look. Thank you very much. Okay, as I mentioned a while ago, you actually have to check the chest wall itself, the external chest wall, and see if there's any deformities on it, if there's any skin problems like lesions, rashes, or any scarring. As for the deformities, he doesn't have any deformities. His breastbone seems to be intact. For other people, sometimes there are deformities wherein the breastbone is sunken in, which we call the sunken chest or the pectus excavatum. Or some people also have a breastbone which is protruding outside, which is called the pigeon breast or pectus carinatum. So far, everything seems to be intact. There's symmetry between the chest areas, and I don't see any too much effort when he's breathing. He seems to be relaxed and breathing well. The movement seems to be fine. He doesn't seem to be in distress at all. I don't see any retractions, anything in the anterior chest wall. He's not using his accessory muscles, which sometimes when people are trying to breathe or try to make an effort to breathe, they sometimes use the sternocleidomastoid or the trapezius muscles to help assist in lifting the ribs up to get more air inside. He's not also doing a diaphragmatic breathing, because with diaphragmatic breathing, you do that when you try to inhale or breathe deeper to allow more expansion of the chest by pulling in the diaphragm inside, which is kind of like this is the opposite thing. When this one caves in, the chest wall actually expands more. As I mentioned a while ago, the rate seems to be okay. He's breathing on a normal rate. He's not tachypnic or the dyspneic. He's not short of breath, so right? He's not short of breath, so we're good with that. And next now is we'll inspect the fingernails for any signs of clubbing. So if you show me your fingernails, please, sir. As you can see, the fingernails looks quite normal. There is no clubbing whatsoever. Then the color is nice and pink. There's no signs of cyanosis or inadequate tissue perfusion. If there are signs of clubbing in there, it could be a an oxygenation problem, which is also related to some sort of heart defect or respiratory defect as well. You can put your hands down, please, sir. So we've done with the inspecting part on the posterior, on the anterior area of the chest wall and everything. Next is though we're going to do the palpation part, in which we're going to place our hands on the chest wall itself. I've already disinfected my hands, so we can now proceed with respiratory excursion. The way to do it is you actually place your two thumbs close to each other against the chest wall, just below the margins of the breastbones. Of the ribs, the costal margins, and observe for your thumbs to spread apart as the patient inspires. So what you do is, as I demonstrate, I'm sorry about this, sir. I'm going to put my thumbs on the costal margins, which is right over here. Place them like that, side by side, with your fingers splayed and grabbing, well, not grabbing, but more of holding the sides. And then you lift up some folds a bit and then ask the patient to inhale. Okay. As you can see, my thumb's actually separated, which means the expansion is symmetrical and the extent of the breathing is good. Pardon me. So we've already established that he's got a good respiratory excursion and the symmetries are okay. Now we can check for tactile fremitus, which is the fremitus is actually the vibrations made along the chest cavity when the person is speaking. So if there is fremitus, then it means that the chest cavity is intact and there's no consolidation. But if there is consolidation, then the fremitus would be more diminished or more faint. So we're going to start with vocal fremitus right now. So as I place my hands on your chest, sir, can you please just say 99, okay?
99. 99. 99. 99. 99. 99. 99. 99.
Okay. I felt the vibration of his voice on all areas of the chest, of the anterior chest. So I didn't see any evidence of consolidation there. So it means that his chest cavity is clear and intact. And yeah, and we're good on that part now. So since you're doing the fremitus, you can also check the ribs, the for costchondral tenderness, which is the cartilage or the connecting part that connects the ribs to the breastbone. So just feel this part over here and just palpate and ask the patient if he feels any pain while doing that. Do you feel any pain doing that?
No.
Okay, so there's no costchondral pain or tenderness at all, so everything seems to be fine. So since we're done with the palpation part of the anterior chest, we can now proceed for percussion, in which the percussion we do on one side at a time, so we can compare the difference between the percussion or the sound or the vibration we get from each side. Because when you do percussion, some consolidations and some masses do not actually occupy on both sides, sometimes only on one side, so you can tell if one side is different from the other by doing so. So we can start percussion right now. So with the percussion, if you're right-handed, use your dominant right hand to tap the other middle finger of your other hand and hit the interphalangeal joint, which is the finger, just the joint right below your fingernail of your middle finger on your other hand. So just place your finger flat down on the skin, raise the other finger so that they won't interfere with the sound, and with your other finger, the dominant finger, use the middle finger to tap that interphalangeal joint and do 2 taps, and so that you can feel any vibration that may resonate inside the chest cavity. So just 2 taps. Good. Do the same for the other side. Okay, and then just repeat the process on each side. And make sure that when you do the percussion, you actually have to put them in between the intercostal spaces, because if you hit the ribs, you're definitely gonna have a dull sound, which you may mistake as a mass, which when there is actually none. So in this case, everything is resonant, which means the chest cavity is intact and unobstructed. There's no consolidation. So also while you're doing the palpation, you might as well check for the liver span, in which the liver is usually on the right side of the chest wall. When you tap on the liver, usually you can feel a dull sound. So all you have to do is look for the space, the costal margin on the 10th rib, and then start tapping from there, and tap for the dull sounds until you reach a resonant sound, which will indicate that you're actually at the end of the liver margin. So tap right over here. There's dull sounds over there, so just follow that across the chest. So that's resonant over there. So from here to there, its approximate span would be around between 6 to 12 centimeters. So I think I can see that it's between between 6 and 7 anyway. So good size lure. So yeah, so the percussion part seems to be fine. And next part will be listening to the chest wall with auscultation. We're gonna, like the percussion part, we're gonna listen to the chest wall on both sides one at a time, so you can compare the sounds from one side to the other. And well, we're doing this so that we find out, see if there's any adventitious sounds that may be present. For people with breathing problems, like with asthma, they usually have wheezing. Some people have rails or crackles or bronchi. So those are the things we're trying to find out with auscultation. So we'll check every side, because one side can be different from the other. So just breathe normally, sir, okay? Okay. We're going to be using the latter technique when you listen to the chest wall, into the lungs. Okay, now we didn't hear any adventitious sounds on the anterior chest wall, which is actually divided into lobes. The right side being 3 lobes, and the other side being 2 lobes. But when you listen to the back, you can only actually hear 2 lobes the most. But for now, everything seems to be clear. There's no signs of any crackles, rails, or bronchi, which is good. Which is my son, actually, Mr. David over here, or Mr. D over here. Actually, I've had a history of asthma before, but there's no signs of wheezing. So yeah, so now we will proceed for the posterior part of our chest examination. So if you can just turn around, sir, so we can actually inspect your back. So same thing as the anterior part. We do the whole process again by inspecting first, checking the back portion of the chest cavity. Like I said, there's no sign of lesions or everything like that. No deformities. There's symmetry in his back, so everything's fine. His respiratory rate is the same. It's between 15 to 25. This chest expansion is normal. There's no respiratory effort going on while breathing. It's not labored. He's not in any distress. He's not short of breath. He's not using his accessory muscles, which is the sternocleidomastoid and the trapezius muscle, but he's not using that right now. And there's no diaphragmatic breathing, because he's just breathing normally. And we've seen the figures a while ago already, and we know that we don't have any clubbing at all. So we should move on to the palpation part. So same thing as the anterior examination. We're gonna check for vocal fremitus on the back portion. We're gonna be checking for the vibrations again. So we're gonna do it on either side at a time, so we can see the difference. So once again, Mr. D, I'm going to put my fingers on my hand, the palm of my hand on your back, and just say 99 as you feel it, okay?
99. 99, 99, 99, 99, 99, 99, 99.
Okay. So there's vibrations felt on both sides of the posterior chest wall. So everything seems to be okay. So now we check for the diaphragmatic excursion, um, which is a way of finding out where the diaphragm is, which is usually at the lower side of the back or in the front. Um, we'll do it this way. So what we do is, well, before we proceed to that, we'll proceed first to the percussion part. I'm sorry. We're gonna do the percussion first. So like that we did on the anterior part, we're gonna percuss his back portion, the posterior part, using the ladder technique, and doing it one part at a time so we can um, see the difference between the two. So same thing, use your dominant hand to tap the interphalangeal joint of the other hand, so, or the other finger, so we can start doing it right now. So I'm gonna tap your back now, Mr. Lee. So we're gonna check for resonance. Okay. Um, Everything seems to be resonant, like the anterior part. There's no sign of consolidation on this side. Everything's on the chest cavity seems to be clear and intact. Um, and like I mentioned a while ago, since you have done a percussion part already, um, we can do the diaphragmatic excursion, in which we try to find out if the diaphragm is in the right place. Should be on the lower side of the back over here. So what we do is search for the end of the costal space here, or you can just start off up here on the 8, 9, or 10 intercostal space and start tapping down. Once you hear a dull sound as you tap down, that will be your marker for your diaphragm. So just in the margins. Okay, this part over here is actually dull. So that could be your diaphragm already. If your diaphragm is actually higher than this rate, it may mean atelectasis or collapse of your lung on either side of your chest cavity. So okay, so we're done with the diaphragmatic excursion, and we're done with the percussion and the palpation. Now we have to do the listening of the breath sounds, which is the auscultation part. So we're going to check for adventitious sounds, like before. We're going to still use the ladder technique. So so we're going to start listening now. So all you have to do is just breathe normally, okay? Okay, so sorry about that. That listens to all the fields of the posterior part of the chest wall, and I didn't hear any adventitious sounds at all. No rallies, no rhonchi, no wheezing, and no crackles. chest cavity appears to become clear and free from any consolidation. And also, while we're doing that, there's also a test that you can actually perform in case you want to find out if there's any consolidation at all, which is called egophony. Egophony is listening to the lungs while the patient actually says the word or um, says E while listening, and you should be able to hear it quite well. Should listen. If there's no if the chest cavity is clear, if there is consolidation, then most of the time or almost all the time, instead of hearing the word E, you're going to be hearing the word A instead. So, Mr. D, as I put my stethoscope in your back, just say E, okay? Okay,
E,
longer.
E, 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 E.
Okay. So, there's no consolidation because I heard this E's quite well. It's not an A, and as far as the tests a while ago, it doesn't also show that he has any mass or any consolidation there. So everything seems to be fine and clear, and that concludes with our examination. And I would like to thank you very much for listening, and I'll see you next time. Thank you.